speaker today. Dr. Daskalakis is chair of the Department of Psychiatry at UC San Diego School of Medicine. He holds the Igor and Joanne Grant Endowed Chair. He earned his medical degree at Queen's University and completed residency training in psychiatry at the University of Toronto. He was a research fellow in the schizophrenia program at the Center for Addiction and Mental Health and earned his PhD at the Institute of Medical Science at the University of Toronto also. Dr. Daskalakis is an internationally recognized expert in treating severe psychiatric disorders with magnetic brain stimulation, also known as transcranial magnetic stimulation, or TMS. He uses TMS to help patients with treatment-resistant depression and is the director of UC San Diego Health's Interventional Psychiatry Clinic. Dr. Daskalakis is a leading researcher in the use of TMS in people with treatment-resistant schizophrenia, suicidal thoughts, and obsessive-compulsive disorders. He's a well-funded investigator with grant support from the Canadian Institutes of Health Research, the National Institutes of Mental Health, and the Department of Defense, amongst others. He has published over 400 peer-reviewed journal articles in high-impact journals and has received numerous awards, including the Laidlaw Prize from the Institute of Medical Research, the Young Investigator Award from the Canadian College of Neuropsychopharmacology, and the Samratiji Lal Award in Mental Health Research from the Graham Beck Foundation. He will be speaking to us today on advances in neuromodulation for psychiatric disorders. Thank you, Dr. Daskalakis.
Thank you. It's a pleasure to be here. Thank you for the kind introduction. I'm told that you can wish people a Happy New Year up until the 10th of the month. That's proper etiquette. So Happy New Year, everyone. Delighted to be here for the first grand rounds of the academic year. The title of my talk is Advances in Neuromodulation for Psychiatric Disorders. And I'll start with my disclosures, which include my sources of funding. It also includes some industry work that we've done over the years, and you'll see the industry, some of the industry work that we've done. Specifically, these two industry partners have supported us at a federal level with grant support from Brainsway, which helped us get off the ground one of our depression treatment trials in geriatrics, and with MagVenture for our magnetic seizure therapy work, and I am on the scientific advisory board for Brainsway. So I was told that I should indulge myself with a bit of history of me. I've never done this before in a grand rounds, but what a great place to start the year. So this is my high school. And I love this idea because it very much personalizes the speaker, and I think as a department of psychiatry, we should start to introduce this. So this is me back in 1994, and these two fellows are both physicians. The one at the top is Mike Michaelides. He is an anesthesiologist north of Toronto, and Gus Meglis, who's a general internist in Toronto as well. These are two very close friends of mine that I grew up with, went to high school with, and I went to high school at Leaside High School. And there's no reason you should know Leaside High School other than it's in a nice neighborhood in Toronto. And Margaret Atwood, who wrote *Handmaid's Tale*, went to Leaside High School. So that is our claim to fame, that it graduated 3 physicians and also Margaret Atwood, and I'm sure a lot of other important people along the way. I then went to the University of Toronto in 1988 to 1990 for undergrad. I studied at these buildings, which, I spent a lot of hours, as we all did, being tortured in medicine, in mathematics, in physics, and in chemistry. And I highlight those departments because those are the departments that provided the greatest amount of torture in my life. But along the way, I did meet this wonderful person, whose name is Dr. Tom Karukis. Got to know him, became good friends with him, and he introduced me to my wife, his sister, Stella Karukis, who's here with me in San Diego. Tom is a hematologic oncologist at McMaster University. I went to Queen's Medicine in 1990 to 1994, worked closely with two very dear friends of mine, Ross McMahon and Danny Lovatzis. Ross is a general surgeon trained at Duke after medical school, and Danny is an OBGYN specializing in urogynecology at the University of Toronto. And along the way, I decided to go into psychiatry. And I can tell you, I was torn. I was really conflicted about my decision to consider psychiatry. I wanted to become an electrophysiologic cardiologist. I was fascinated by waveforms and thought that waveforms would be the future. Waveforms in the heart would be the future of understanding how to mobilize the heart and optimal heart function. But got a really good mark in psychopharmacology and was fascinated how pharmacology could affect and influence the brain and behavior. And so decided to go into psychiatry, knowing that in Canada, if I wanted to change my mind, I could do so relatively easily. And so I went into psychiatry thinking I'll be fine for a couple of years. And if I radically changed my mind, I would go into medicine, but stayed in psychiatry. And I stayed in psychiatry largely due to these three people. I'll start with the right, who's Bob Zafiris. Bob is a schizophrenia specialist, studied at Stanford, moved to Toronto, and started the first episode psychosis program, which really at that time was at the forefront of biological psychiatry. Bob was an absolutely wonderful mentor. Ivan Silver, geriatric psychiatrist at the University of Toronto, who encouraged me not only to stay in psychiatry, but encouraged me to go into academic psychiatry. And then finally, Shatish Kapoor. And Shatish is the type of person you want to emulate yourself after. He was wonderful, incredibly, actually, he was brilliant, not just bright, he was brilliant. Was the top medical student at the All India Institute in Delhi. Went on to go to Pittsburgh to do a fellowship in psychiatry, came to Toronto and helped start the first episode psychosis program, became a positron emission tomography expert, then went on to be the youngest dean of psychiatry at the Institute of Medicine, Institute of Psychiatry in London, England, then became the dean at the University of Melbourne, and is now the president of the Institute, the president of King's College in London, England. So just an incredible ascendancy in his career. And as I say, I've been sort of trying to keep up with him, but it's real hard to keep up with Shatish. He has accomplished so much and is so skilled. And I mention these three people because, again, we're all the product of our environment, and to be able to emulate yourself after these three wonderful people was something that I was a fortuitous encounter in my life, and I cherish those days vividly. So between 1994 and 1999, I was a resident in the Department of Psychiatry, and then between 1999 and 2002, I completed a neuroscience PhD at the Institute of Medicine at the University of Toronto. So, yeah, of course. I'll work on. No. So what did Shatish do for my career? Well, he did a lot, but one thing that he did is Shatish came to me, and it was 1998, and I remember it fondly. Came to my office with these two big boxes and said to me, "Jeff, are you interested in stimulating the brain? This is going to be the future of psychiatry." And I thought to myself, sure, anything you say, Shatish. I'll stimulate the brain. I will review all these massive textbooks that you have in front of me, and I'll try to get this off the ground. And Shatish introduced me to motor neurophysiology. At the time, I thought I was going to get into treatment studies and depression, but he said, no, this is all about motor neurophysiology. You'll do a PhD in motor neurophysiology, and then the rest of the way you're on your own. And so, what is TMS motor neurophysiology? Well, it involves a TMS coil, which is an electrical field that travels through copper that induces a magnetic field, stimulates the brain. Remember, I said I wanted to become an electrophysiologist. Well, I actually did become an electrophysiologist, just in the mind, in the brain, and not necessarily in the heart. And so we stimulate the motor cortex, and we get the hand to contract, and we record motor evoked potentials in hand muscles. So you stimulate in the motor cortex, and 20 milliseconds later, you get an MEP. And there's an incredible amount of information you can deduce just by that simple physiological recording. In fact, because of Satish, again, fortuitous encounters in my life. The first fortuitous encounter I already mentioned, I didn't mention how I met him. I was on call one night. And the reason I still take call is because these chance encounters are wonderful. I was on call one night, met someone who told me, you've got to meet Satish if you're interested in studying the brain in psychiatry, and didn't know how to spell his last name, but I figured it out, contacted him, and he came and was the discussant at my grand rounds way back in 1996. Robert Chen is a neurologist, had just completed a fellowship at the NINDS and moved to Toronto, got a faculty appointment, and was literally a mile away from our hospital. And he was a TMS expert, just finished a fellowship in neuromodulation with Mark Hallett, Mark Hallett, Eric Wasserman, and Leo Cohen at the NINDS, who were TMS experts, really established the foundation for neuromodulation in neurophysiology. And so between the two of those folks, I studied the simple hand contraction and being able to deduce electrophysiological signals from that simple hand contraction and what it meant at the cortical level. And in fact, what it meant was we could measure these inhibitory influences of motor cortical neurons, and those small little inhibitory influences that were mediated by short-acting GABA A and long-acting GABA B, we could deduce those neurophysiological influences and looked at patients with schizophrenia. And so I started to work in the clinic, recruiting patients with schizophrenia into my trial. We published a seminal paper back in 2002. It's one of my most highly cited papers, establishing inhibitory deficits in schizophrenia, specifically in first episode schizophrenia. And I recall vividly, as I was responding back in 2000, when I submitted this paper to the Archives of General Psychiatry, I submitted the paper, I got to revise and resubmit. I was over the moon and responded. It took me 6 weeks to write the response letter. My response letter was 33 pages long. And submitted it, in this big box, sent it off to the Archives of General Psychiatry. And about 5 weeks later, I got back a response. And the response included a handwritten note by the editor of the Archives of General Psychiatry. At that time, it was the top psychiatric journal in the world. A handwritten response from the editor that said, "Dear Dr. Daskalakis, your response letter was a masterpiece." And it was the time in my life which was quite profound. You can see I'm already getting a little bit emotional over it because it set me on my career in academic psychiatry. And so I've had the wonderful fortune of not only being mentored, but also mentoring incredible people. And along the way, I've mentored all of these wonderful clinician scientists. They're too numerous to mention, but they all came through a hospital that I worked at, which was the Center for Addiction and Mental Health. Lots of psychiatrists here, lots of psychologists here, and folks who were incredibly committed to the work that we were doing. I want to highlight a few key people along the way. Corey Weissman, who joined me in 2016. Corey is actually here with us at UCSD now. And he is actually the director of the interventional psychiatry program. I started the program when I moved here, and we managed to entice him to come and join us here. He wanted to move to the West Coast anyway, and so I think he loves it here, and he's a very valuable addition to the team. Dan Bloomberger is one of my closest personal friends. I met him. He was doing elective rotation with us in the schizophrenia program in Toronto. Called me and he said, I'm thinking about doing research in psychiatry. I said, come and join us. We'll do incredible things together. And then he thought about it. He said, can't come. I'm sorry. I committed to someone else. I said, well, too bad, Dan. Good luck in your career. He left. 3 months later, he called me. He said, Jeff. I said, Dan. He said, I'm in. And Dan came, and Dan's published probably some of the most influential, important articles in our field, including a paper in Lancet Psychiatry that I'll talk about, in Lancet, that I'll talk about, that led to the FDA approval of intermittent theta burst stimulation for depression, and a whole host of other people that I've worked with. Lindsay Benster is currently my graduate student here at UCSD, my first graduate student at UCSD. Okay. So STAR-D, you folks won't know about STAR-D necessarily. Some of you may, but STAR-D was a pivotal clinical trial published way back in 2006. And what STAR-D demonstrated was that after two trials of antidepressant medication, if you fail 2 trials of antidepressant medication, the likelihood of responding to antidepressant medications is actually quite low. Well, you may ask, how low? Well, the figures are there. The data is there. It's about 13%. And I'll show you a slide soon, which shows you that 13% is no better than placebo. And so 13%, so if your patient with depression does not respond to 2 separate trials of antidepressant medication, the likelihood that you're going to get them better after a 3rd and 4th trial is no better than placebo. Also, patients relapse at extraordinarily high rates. Even when they do initially respond, you can see that 50% will relapse at about 6 to 12 months. And what does that lead to? Well, it leads to this little sticky that I took a photo of off my desk in a kind of a frivolous way, but I recognized that it was important and really an exemplar for what goes on in a lot of our patients. And that is, they're on numerous medications, often not evidence-based, and people kind of shooting in the dark trying to get these folks better. And so lots of patients do not respond. How many? Well, about a third of patients with depression will not respond to conventional antidepressant treatment, which leaves us with a huge treatment gap. So I mentioned placebo response. So Brett Jones was one of my clinician scientists. He's now a fellow at the Center for Addiction and Mental Health. And Brett and I thought, well, we know what the placebo response rates are in depression, but how about treatment-resistant depression? So we spent a few years, Brett spent a few years, I was just observing and watching and supporting, and he analyzed, I think it was over 1,000 papers to come up with this very select group of papers looking at placebo response from numerous clinical trials in resistant depression. This was relevant because we needed to establish what our placebo response rates were to be able to deduce whether or not therapies are significantly better and not just continuously randomize people to placebo, which is valuable, but it becomes problematic when you're trying to recruit at high rates. And so what we found was the placebo response was about 1 in every 7 patients. So 1 in every 7 patients with resistant depression will respond to a placebo, not only respond, will remit. And there's a difference between response and remission. Response is a 50% improvement in depressive symptoms, and remission is no depressive symptoms. So 1 out of every 7 patients will achieve remission even when they've received a placebo, and just underscores the earlier point that I made, that after 2 failed trials, you're not doing much better than placebo. So Helena Kim. Helena did her PhD and then went to medical school and joined the clinician scientist program. She was my clinician scientist trainee. Helena was is one of those trainees who will, you generate an idea with her, and 2 weeks later you have a paper in hand. Incredible in terms of her productivity, and I think she's just knocking it out of the park right now in Toronto. She was one of the first people I thought of trying to recruit here, but she was only in PGY2 at the time of that I left, and so still trying to recruit her here. But she published this important paper, and this is relevant to this audience because this is antidepressant response in patients with severe medical illness. So if you have, I often see patients on consult liaison or as, consulting to medicine, and we see lots of patients, obviously, with depression. We have to make a decision as to whether or not to start medications in these folks. But in the back of my mind, I'm always thinking about this paper, and I'm thinking, are we actually doing any better than placebo when we start a lot of these medications? And her data suggests that in patients with comorbid psychiatric illness and comorbid medical illness, the therapeutic efficacy of antidepressants in that population is severely limited and just a bit higher than the placebo response rate. So a lot of these medications that we use to treat depression in comorbidly medically ill patients may not be as efficacious as we think. Okay, we talked about depressive symptoms, but in my clinic, I often see patients with severe depression who have suicidality. And, I don't need to tell this group or any other group that suicidality is a particularly frightening, incredibly morbid outcome of depression. Fortunately, it doesn't happen that often, but patients are often labored with suicidal thoughts. And when they have suicidal ideation, they struggle to get better. And Corey's data, this is one of the projects that Corey took on when he first became a clinician scientist with me. He went back into that STAR-D data set. And I can tell you that STAR-D data set was collected between 1999 and 2004. It was all in Excel and it was a mess. We went to the National Data Archive. We extracted it and it was this massive tome of data that was thrown into an Excel spreadsheet. But after 1 year of reorganizing the data and reconstituting the data in a way that we could analyze, Corey and several others managed to extract a very important signal. And that signal was when you use antidepressants in patients with depression who are suicidal, your overall efficacy is greatly diminished. And this is an example not just of that point. In other words, if you have suicidality at baseline and you see your psychiatrist, the likelihood that you're going to be resistant after treatment is a lot higher. The other thing that Corey demonstrated is not only are you more likely to be resistant, but remember I said earlier that you needed 2 trials of antidepressant medications to respond at least 60% of the time. Well, Corey's data suggests that a lot of people improve with depression who have suicidality after the first trial, but if you don't respond after the first trial, your likelihood of getting better is greatly diminished. So the presence of suicidality predicts non-response to antidepressant medications. So where does that leave us? Well, I had a young guy that I saw in clinic. Family came to me and said, look, he's really, really struggling. And now finally he has suicidal ideation, and he had actually attempted to kill himself once before, 5 or 6 years ago. And I knew exactly what we needed to do. It's a difficult decision to make, but the decision to me was obvious. And now he's recovered and he's doing a lot better. And that treatment is electroconvulsive therapy. It's one of the most efficacious treatments we have in medicine. It is also one of the most stigmatized treatments that we have in medicine. Incredibly efficacious. 75% of patients with depression, severe depression, will remit to this treatment. It's not for everybody. And only about 1% of the treatment-resistant patient population will actually undergo ECT. So let me frame things in a slightly different way. San Diego is a city of about 3.5 million people. The number of patients with depression in San Diego should be about 200,000 based on population health statistics. That leaves about 80,000 people in San Diego with resistant depression. Out of those 80,000 people, only 1% will go on to get ECT, just because ECT is rarely used. It has side effects associated with it. It's stigmatized, and it's just not that widely available. And so we need novel interventions. We have a huge proportion of the population, San Diego alone, potentially 79,000 patients who are not going to respond to antidepressant medications, but need better interventions. And so that's where transcranial magnetic stimulation comes in. And remember, I mentioned earlier that we stimulated the brain, the motor cortex, and we got a contraction in the hand muscle. Well, it turns out that at that time, people were stimulating just in front of the motor cortex in a place called the dorsolateral prefrontal cortex, which, as you know, is the brain region that we think governs executive function. And we used very crude methods at that time to stimulate the dorsolateral prefrontal cortex, crude methods in terms of targeting. But suffice to say that TMS, because of those early trials, was approved by the FDA in 2007 as a treatment for depression. It involves a magnetic field stimulating the dorsolateral prefrontal cortex repetitively every day. The treatment itself used to take 40 minutes every day for about 4 to 6 weeks. And when you did that, you achieved significant therapeutic efficacy. How efficacious is it? Well, this is a big meta-analysis that we published way back in 2014, looking at a number of trials, including our own and several others. And what we found was that 1 out of every 3 patients responded to treatment, and 1 out of every 5 patients remitted to treatment. Now, remember, I said 1 out of every 7 patients remits in response to placebo. So the efficacy was better. It wasn't as efficacious as ECT. Be that as it may, it was approved by the FDA and routinely used. Now, again, these are according to methods way back in the early 2000s. A trial that we published in 2016 looking at different ways of optimizing. So how do we make TMS better? And what we did was, rather than stimulating specifically over the left prefrontal cortex, we stimulated over the left and right prefrontal cortex. And we extended the number of pulses to really try to squeeze out as much of the brain's neurophysiology as possible. We did something also very different at that time. And that is, we were one of the first groups to use neuroimaging to guide our treatments. Okay, so you can find the dorsolateral prefrontal cortex, and the way we used to find it was we used to draw a line from the motor cortex, parasagittal line, 5 centimeters anterior from the motor cortex, mark that spot, put the coil over that spot, and stimulate away. And of course, that's not the way to stimulate the brain. There's no precision there. And so we use neuroimaging to guide our treatments. Now, the problem with the dorsolateral prefrontal cortex is that it's not an anatomic target. It's a functional target. So how do you know whether or not you're stimulating in the right place? Because it's functionally guided. It's not anatomically guided. Well, I had the good fortune of working with an important collaborator of mine over the years. We're now co-PIs together on a grant from the NIMH. And what we did at the time was we looked at a meta-analysis of functional imaging findings, and actually through that meta-analysis, we're able to identify the region of the brain that was most hypoactive in depression. It happened to be in the dorsolateral prefrontal cortex, and that was where we stimulated. And our efficacy did get a little bit better. Not much better when we did all that work. It was a huge undertaking, lots of effort, but it got a little bit better. It went from 1 in every 5 patients to 1 in every 4 patients. So we thought, well, how about its effects on specific symptom targets? So Corey went back, analyzed 2 big papers that we published in the treatment of depression, and collapsed those papers and specifically looked at suicidality as a symptom dimension of depression. And so he looked specifically at suicidality and found that in patients with depression, a significant proportion of patients got better from their depressive symptoms, but even higher rate, doubling of the number of patients who remitted in response to suicidality, specifically when both sides of the brain were stimulated. So what Corey demonstrated is, if you stimulate bilaterally over the left and right prefrontal cortex, you can get 1 out of every 2 to 3 patients into remission from their suicidal ideation. This is not an unimportant finding. And the reason for that is obvious. If you're experiencing suicidality, the ability to suppress your suicidal thoughts with TMS rather than moving to ECT is a substantial therapeutic benefit. And Corey's applied for a K to be able to work on this very specific finding. Okay. So as we learn, we innovate. And there was a lot of innovation that was done in the mid-2000s. And the type of innovation specifically was in the patterning of stimulation to the brain. In animal studies, in rodent studies, they had done something called theta burst stimulation. And theta burst stimulation was done specifically to enhance neuroplasticity in the cortex. So what is theta burst stimulation? Typical TMS involves stimulating the brain at different frequencies, but with single pulses. So imagine if I took a single pulse and I divided it into 3. That's the burst. So instead of delivering 1 pulse, I deliver 3 pulses in quick succession. How quickly? at 50 hertz. So a pulse very quickly, triplet pulses delivered every 20 milliseconds. It's so fast you can barely hear it. It's real rapid. And that triplet pulse delivered every 20 milliseconds or at 50 hertz is then delivered every 200 milliseconds. So 3 pulses delivered at 50 hertz on a 5 hertz rhythm. That's why it's called theta burst stimulation, because in the brain, the 5 hertz rhythm is the theta rhythm, and the burst is this triplet pulses. And that is delivered in rapid succession. And there's 2 ways of delivering this, through intermittent theta burst stimulation and continuous theta burst stimulation. Don't worry about continuous stimulation, but the brain has, as we all know, is an incredibly complex organ and has a few tricks up its sleeve. And so we were able to biohack the brain, not we, this clever group at the Institute of Neurology in London, England, where they realized that if you stimulate with theta burst stimulation for 2 seconds, and then you have a 10-second gap followed by 2 seconds of stimulation, followed by 10 seconds, you produce this wonderful response in these motor evoked potentials. As I told you earlier, the motor evoked potentials gave us a unique window into the functioning of the brain. And so theta burst stimulation delivered in this intermittent pattern was able to produce a 50% enhancement in neuroplasticity immediately after the treatment. So there were 2 things that were discovered as a result of this. This was a paper that was published in 2005 in Neuron. There are 2 things that were discovered. First, you could rapidly pattern stimulation in the brain. This duration of stimulation is only 3 minutes long. So you can stimulate the brain with a lot of pulses in a very short duration of time, and you can reliably produce neuroplasticity. So clever group out of Taiwan realized that they could use theta burst stimulation. Instead of using the traditional type of stimulation, they could use theta burst stimulation depression, and had these very convincing findings, which was that when you stimulated the brain bilaterally, you could produce response in over 50% of patients. And this was a paper that was published in Brain back in 2014. So we capitalized on this finding. When I say we, I mean the team that I work closely with, Dan Bloomberger and Jonathan Downer. Jonathan was a clinician scientist in Toronto, MD, PhD. Dan Bloomberger was one of my fellows, but also a very close personal friend and someone I work very closely with, also a psychiatrist. And the 2 of them got together and produced one of the largest clinical trials in psychiatry. And, you know, by psychiatric standards, we don't produce a lot of large clinical trials. But what they did was they randomized in a non-inferiority clinical trial 414 patients. Half of the patients got randomized to intermittent theta burst stimulation, and half of the patients got randomized to the standard form of TMS that we've been doing all along. And what they found was non-inferiority, meaning that the 2 treatments didn't differentiate themselves from one another. They had the exact same clinical outcomes. Those clinical outcomes were 50% improvement in 50% of patients with depression, and about a third of patients reached remission, and similar for the 10 hertz group. So this is what is basically indicated by non-inferiority. In other words, the 2 groups were not statistically different. It's not just that they were not statistically different from one another. It's a different methodology to be able to evaluate non-inferiority. And it's a lot more rigorous, requires a lot higher sample size. And they were able to demonstrate non-inferiority in a big clinical trial published in Lancet in 2018. And this clinical trial was reviewed by the FDA, and it led to intermittent theta burst stimulation being approved by the FDA for the treatment of resistant depression. And it is the reason why across the US now, we are using intermittent theta burst stimulation almost exclusively to treat depression. So for us, very exciting. Why would we want to use intermittent theta burst stimulation? Is it just about neuroplasticity? The answer is absolutely not. It's about the timing. You can deliver an effective treatment using theta burst stimulation in 1/10 the time that standard TMS was used to treat depression. So from an efficiency perspective, you can really increase the number of patients that you need to treat. At least that's what we thought at the time. But what you can also do, I'm getting ahead of myself. I'll get to that in a bit. hold on to that thought. This was a second trial. This is in geriatric depression, where we conducted another non-inferiority clinical trial using standard theta burst stimulation, except delivered bilaterally compared to standard TMS. And what we found again was non-inferiority between these two populations. This is a paper that was published in JAMA Psychiatry. We specifically used bilateral theta burst stimulation because we were interested in the enhanced efficacy of stimulating bilaterally, and achieved nearly the same results that we did in that first original paper, slightly enhanced and in a geriatric depression sample. Okay. The NIMH has pivoted. The National Institutes of Mental Health have pivoted. And unlike a lot of other institutes, they are really after biological target engagement. So, you know, in medicine, that is a relatively straightforward, intuitive concept. Patient has diabetes, you give them insulin, it brings down their blood sugars, and you can measure those outcomes. Revolutionary back in the 1920s and 1930s, but now is pretty standard fare. In psychiatry, we don't have those biological measures. We just, they elude us. And so the NIMH has now pursued a different strategy, which means that whenever you conduct a clinical trial, you have to identify a biological construct. You have to be able to understand what is going on in the brain. You just can't submit a traditional clinical trial to them. First, you have to demonstrate what's called biological target engagement, and then you have to demonstrate efficacy through a very specific mechanism. And so I've been interested in biological target engagement for a long time. As I mentioned earlier in my career, I was interested in the neurophysiology of schizophrenia, pivoted to the neurophysiology of depression. And with Andrea Levinson, one of my first fellows, we published this paper in Biologic Psychiatry, and we demonstrated that patients with depression had inhibitory deficits in their brain. Their GABAergic neurons were not functioning as effectively as they should compared to patients who did not have depression. And in fact, it was the treatment-resistant depression patient sample that had the greatest GABAergic deficits, which was important because we thought that TMS and ECT both exert some of the therapeutic mechanisms of action. And over the next few slides, I'll try to emphasize that point. That was a non-trivial task. This finding was demonstrated in the motor cortex, but you know, in psychiatry, we're not so interested in the motor cortex. Neurologists are very interested in the motor cortex. The motor cortex just isn't as important as some of the other cortical regions, including the dorsolateral prefrontal cortex. And so this question was not just a question that came up recently. This actually was first mentioned to me by Shatish, who said to me, Jeff, said, you know, the motor cortex, I know you're excited about the motor cortex. You got these great findings, but no one in psychiatry is going to care about the motor cortex. Why don't you look at a more relevant brain region? Well, again, non-trivial, because we could stimulate the motor cortex and activate hand muscles. But when you stimulate the prefrontal cortex, you have to record it in some other fashion. And that fashion was through EEG. But stimulating with an electromagnetic pulse and recording electromagnetic pulses without demonstrating artifact was an engineering impossibility back in 1997. I flew and spent a month in Finland. It was the only group in the world to be able to do that. Learned a lot during that trip. Flew back to Toronto. And then about 4 years later, my friend and colleague Paul Fitzgerald called me and said, hey, our new EEG amplifiers can probably extract a lot of the signal, and let's tinker with this and try to get it to work. So I flew down to Australia, read one of the Harry Potter books all the way there. I think it was Goblet of Fire. Landed in Australia, started recording, and we had this day where it was our last recording day, and we had to decide whether or not we were going to record or go out and have wine in the vineyards outside of Australia. And you know, we were dedicated scientists, and we said, no, let's stay. Let's finish our recording. So we did, and on that day, we recorded what looked like a very promising electrophysiological signal that as I flew back, I was incredibly excited. I don't think I slept a wink on that flight back from Australia to Toronto, because we finally recorded what I thought was a meaningful neurophysiological signal from the prefrontal cortex using TMS combined with EEG. This is the waveform that you produce. You get these nifty little electro EEG depolarizations, and specifically these waveforms, the N45, the P60, and the N100, actually, again, give you clarity as to what is going on in the brain in relation to excitatory and inhibitory mechanisms. So with Daphne Voinescos, she was one of my clinician scientists. She's now a federally funded clinician scientist in Toronto. We published this paper looking at the biological mechanisms of TMS on the brain, and found that patients with depression who had baseline inhibitory deficits didn't respond as well, and that the treatment itself actually enhanced inhibitory mechanisms in the brain. The reason it does that is because the brain, when it's stimulated, responds. And when you're stimulating the brain in ECT, you're producing a seizure. ECT, that seizure is terminated through a wave of GABAergic influence that suppresses the seizure. It's the reason why we give lorazepam to patients who are convulsing in status. And so similarly, when you're stimulated with an electromagnetic pulse, you actually induce a wave of inhibitory neurotransmission. And that inhibitory, the amount of inhibitory neurotransmission that was generated with TMS was related to the therapeutic response, which we showed here. Okay, back to that original finding that I told you. So theta burst stimulation induces neuroplasticity and induces inhibitory and excitatory neuroplasticity. I know this is a lot to consider, but the treatment itself is 3 minutes long. And I thought, great, we'll be able to treat 10 times as many patients. Well, it turns out that not only can you treat 10 times as many patients, theoretically, it actually ends up working out to about 1 or 4 times as many patients when you take into consideration you have to bring the patients to the room, stimulate, all that takes up a lot of time too. But you can stimulate them repeatedly. And so Nolan Williams, who's a brilliant young neuroscientist, he's at Stanford, originally trained at MUSC, created this program, this paper that was published, several papers that were published, and the approach is called the Stanford Neuromodulation Therapy, SNT, which then got converted to SAINT. And what it is it's an accelerated form of ITBS. So there were 2 parts to this that were important. The first I mentioned briefly to you. It's stimulating the brain for 3 minutes. But instead of stimulating the brain for 3 minutes over 4 weeks, he stimulated the brain for 3 minutes 10 times a day over 5 days. That was the first paper. Then what they really went after was, where in the brain should we be stimulating? There's a lot of interest right now in the cortical, subcortical connectivity in depression, specifically in an area of the brain called the subgenual cingulate. Subgenual cingulate was one of the first targets through deep brain stimulation in depression. Those trials failed, but we've since found out that if you stimulate the prefrontal cortex through connectivity, you can actually record and influence the subgenual cingulate, again, an important hotspot in depression. And Nolan identified the area of the brain in the dorsolateral prefrontal cortex, which could be used to maximally activate that subgenual cingulate region. So between multiple sessions a day and specifically targeting the brain with TMS, trying to influence the subgenual cingulate, he produced several key papers, one in 2018, one in 2020, and one in 2021. And it's not just that they were able to get patients better after 5 days, which they did. In other words, patients could have years and years of depression and be better after 5 days with these 10 treatments per day for 5 days. But the amount of improvement was substantial. In the early papers, about 90% of patients were able to get 50% better, and about 75% of patients reach remission. Reaching remission after 5 days of treatment, 75% is even better than ECT. So this is one of the most interesting areas that we have right now in psychiatry. because it's truly, I think, one of the greatest advancements in our field, the ability to achieve rates of remission at high rates by precisely targeting the dorsolateral prefrontal cortex in an effort to influence subcortical activity. Okay, so I'm going to shift gears a little bit, but not dramatically so. How will I shift gears? Well, when TMS fails, the next step traditionally has been electroconvulsive therapy. But in the early 2000s, in fact, in 1999, I went to a conference in Prague. It was not a psychiatric meeting. It was a neurophysiological meeting. It was the International Federation for Clinical Neurophysiology. And at that meeting, there was a presentation by Holly Lisenby, who's one of the division directors now at the NIMH. And Holly presented on magnetic seizure therapy and showed that you could use a magnetic coil to induce a seizure in the brain. It's for all intents and purposes, a large TMS coil that stimulates at very high intensity. And it's a large coil, so it activates a tremendous amount of real estate in the brain. Be that as it may, it actually stimulates with a lot less energy than electroconvulsive therapy. And you can see the hot colors are the amount of energy that are required to produce a seizure in the brain through ECT. And you can see the much cooler colors that are used to produce a seizure with with a large magnetic field. That's just a representation of the amount of energy that is required. And you can see the significant drop off. But what you also see here is that in deeper regions of the brain, they're nearly untouched with magnetic seizure therapy, but greatly affected with electroconvulsive therapy. So we conducted a large clinical trial. This was years in the making, an enormous effort, a lot of persistence. They say persistence pays. There was a lot of persistence here because we had to import a large, this piece of equipment that was still experimental all the way from Denmark to Toronto, run a clinical trial, deal with all of the complexities of a large clinical trial, being one of the first groups in the world to do this work, and published this paper in 2020 after years of doing these clinical trials. And what we showed was that at high frequencies, stimulating the brain with magnets at high frequencies to produce a seizure, produced in the per protocol, produced remission rates over 50%. We lost a little bit of the efficacy between when we dropped the frequency to moderate frequency and low frequency. What was interesting here is we were able to induce seizures in the brain through magnetic fields at all frequencies. And so why would we do this? Why, this is a question I had early on when as excited as I was to see a magnetic field inducing a seizure in a patient, I thought, well, what's the difference? Why can't you just use an electrical field to induce a seizure? And the electrical field intensity in the brain was key, because the lower the energy that is required, the lower the energy that affects the hippocampus. Hippocampus is spared, and what you have is nearly neutral cognitive effects. There was absolutely no difference. Here are all the different cognitive tests. Remember, I told you these are complex trials. These are all the separate cognitive tests that we did in this trial to really try to ascertain any signal of cognitive impairment that we see in ECT with treatment. And there was very little change with magnetic seizure therapy. One of the autobiographical memory tests did show a significant decrease, but it turns out that significant decrease was just a time effect. It wasn't a treatment effect. And the reason we know that was we saw the exact same amount of worsening of their autobiographical memory in pharmacological trials. And it turns out that it was just, as we study a piece of material, it's very fresh and we're able to recall it early on, but over time that your ability to recall new learned information just decreases. And so that decrease was more of a time effect, and now we're using additional tests. What we also saw was a significant decrease in suicidal ideation. So Corey's, another important paper that was published by Corey back in 2020, showed that different frequencies produced different effects on suicidality. So some frequencies produce better effects on depressive symptoms, and other frequencies produce better effects on suicidality. Yinming is now joined us here at UCSD. He was my PhD student in Toronto. He is not a psychiatrist. He's a biomedical engineer. And Yinming was able to take those waveforms that I kept referring to, these waveforms of inhibitory tone in the prefrontal cortex, and actually produce one of the strongest signals around biological target engagement. He showed that when a patient population had a very robust inhibitory neurotransmitter mechanism in the brain, they were able to produce remission of their suicidal symptoms 9 out of every 10 times. And so through this complex neurophysiology, we were able to predict who responds to magnetic seizure therapy versus who does not. He also demonstrated in a separate paper that magnetic seizure therapy, not only does it affect inhibitory neurotransmission, but actually induces neuroplasticity in the brain, an important finding that may have implications in Alzheimer's. That led to a very large clinical trial that we got funded by the NIMH that is still ongoing. COVID set us back about 2 or 3 years, as you can imagine, but it's ongoing. It's now available here at UCSD. It's 3 sites: Center for Addiction Mental Health in Toronto, UT Southwestern in Dallas, Texas, and now here at UCSD. And it's another non-inferiority trial, but it's also a superiority trial. So it's a non-inferiority trial in relation to clinical outcomes, superiority in relation to cognitive outcomes. And the hypothesis that MST will be as efficacious as ECT for the treatment of depression, but will be significantly better in terms of its cognitive outcomes. Jenna Trainer was a clinician scientist trainee of mine. She's a psychologist. She's now in Boston, working at McLean. Jenna and I and Anthony Ruocco came up with this idea of looking specifically at suicidality, but not just in depression patients. So we have a very large cohort of patients who have chronic suicidality in relation to borderline personality disorder. Those of you who have interacted with those patients, but you realize they're incredibly difficult to treat. They often make the physicians' lives quite difficult, but their own lives, they personally struggle a tremendous amount with borderline personality disorder. They're chronically suicidal, and sometimes, regrettably, they kill themselves. And so this is a patient population that just does not respond to conventional treatments. We'd had a cohort of patients who underwent ECT and saw some miraculous findings in those patients, with upwards of 2 out of every 3 patients achieving near total remission of their depressive symptoms and suicidal ideation. And yet ECT leaves you with all of these cognitive side effects. And so we use magnetic seizure therapy to treat this patient population. It was a small trial. It was very hard to recruit these folks. But what you can see here is a significant reduction in suicidal ideation in a small group of 8 patients. There's a paper published in Nature Mental Health. And so what we found here was, again, not only improvement in depressive symptoms, but a significant reduction in their suicidal ideation and self-harm attempts as a result of magnetic seizure therapy without any cognitive impairment. I will skip ahead because I realize I'm probably running out of time and I want to leave time for questions. Lots to chew on. This slide, and I'll just get to I'll focus on the punchline here. I mentioned the subgenual cingulate. Through our neurophysiological techniques, not only are we able to evaluate inhibitory and plastic mechanisms at the surface of the cortex, but through some complicated analyses that were generated by Itai Hadass and Yinming, we were able to demonstrate a neurophysiological signal without actually recording from deep brain structures, by recording from superficial brain regions, deduce a neurophysiological signal that was related to subgenual functioning. And that's in a few of our large trials right now. That's one of the main neurophysiological signals that we're pursuing in the context of depression. I will continue to skip ahead and just summarize. Thank you for your time today. Neuromodulation is an exciting field of treatment in depression. particularly when medications and psychotherapy do not work. Both RTMS, MST are highly innovative areas that are continuing to innovate. And there's a lot of work being done right now to establish the biological basis. But large clinical trials are currently underway. We have large clinical trials that are underway. These are some of our trials. These are trials that are funded by the NIMH and Wellcome and several other agencies. And so we have an entire pathway where patients come in and they get triaged to different trials, or they just receive conventional treatment. And the last slide is just an acknowledgement. These are mostly folks from Toronto, including the Temerdys, who are right there, who were incredibly generous to us, got us off the ground when a lot of other people were not touching this work, made $250 million gift to the University of Toronto and have the medical school named after them. So I hope I was able to share with you some exciting trajectory in my personal history, but also an exciting area of innovation in our field. Thank you.
Thank you so much, Dr. Daskalakis, for that very interesting and thought-provoking presentation. Do we have any questions from the in-person audience here in the auditorium?
Thank you for that. So one question is, there must be some relapse rate after getting the version of TMS or MS, and what might that be? And also, I know for ECT, sometimes people need maintenance therapy to keep it going. Is that the same for TMS or MS?
Great question. So just to repeat the question, what is the relapse rate with both TMS and MST? So the relapse rate we've historically known with ECT is quite high. It's about 80% at 6 months, extraordinarily high. So the faster treatment works, the more likely it is that you're going to relapse if you don't maintain the treatment. There's been a lot of work that's been done in this area in relation to ECT, not a lot of work that's been done in relation to TMS, and certainly not a lot of work with MST. The MST still needs to be done because MST is a relatively new treatment. We're still evaluating it in a non-inferiority trial, apropos the earlier slide I showed you. That trial is registered with the FDA, so the approval of that treatment will, the publication of that treatment, if it's positive, will lead to FDA approval. RTMS has never been established a clear line of evidence around maintenance. So we have different strategies, but we do intervene periodically. One strategy is just to wait till people relapse. The problem with waiting till people relapse is sometimes they don't respond after they relapse. And so to maintain them, we do have a strategy. It's not necessarily the most evidence-based. But the problem is that the NIMH itself is not funding these clinical trials that are needed, and so without biological target engagement. So the punchline is we are actually going to submit a trial now with Paul Fitzgerald in Australia to the NIMH involving ourselves, Cornell, and Australian National University to be able to tackle that question. But suffice to say that we do know that maintenance strategies are important. Sometimes you can use medications to maintain people. There was a big paper that was published in 2000 in New England Journal showing that when you use nortriptyline, this was 2000, so nortriptyline plus lithium, you can maintain people very effectively after a course of ECT if they didn't want ECT. And we maintain the vast majority of our patients on an outpatient basis, which is why outpatient ECT is so important to offer and something we were not doing before.
Thank you very much for an interesting talk, Dina Rifkin. I'm a nephrologist, so forgive me for drawing an analogy to the heart. So you started off talking about electrophysiology, and it seems like ECT is more like the commotio cordis of, it's like the thump to the chest that is kind of a random event, and you're trying to hit a particular vulnerable signal, right? So I guess I'm wondering, when we see electrophysiologists go in, right, they're taking signals and getting it back and looking for the right spot the whole time that they're trying to do something. Are you looking to, is there a plan to try to get a feedback loop going so that you're monitoring while you're TMSing, or, what's the next step?
That's a phenomenal question. So closed loop systems, we call them closed loop systems. Closed loop systems are tricky. And the reason is because to be able to close the loop, you have to actually be able to record directly from the brain. You could record through EG, but the signal isn't as clean as recording from the brain. So it's currently being evaluated. I'm not sure if there are large trials. I can tell you that we are now in discussions with Sharona Benheim in the Department of Neurosurgery to be able to do some of this work. In fact, our hope is that we can actually use implanted electrodes to both record and stimulate at the same time. It's not for everybody, but if you have a particularly recalcitrant patient who has depression, and you can stimulate and record, that closes the loop. And that's what we're hoping based on some of these physiological signals.
Hi, this is working, right? Okay. I have a question. How, I guess just on the accessibility of TMS to our patients. I haven't seen it like used before in one of my patients, so just curious.
Sure. So how do we improve accessibility, or how do you refer to us?
Commercial insurance covered.
Thank you. I'm only 3 years in the US, so I'm still trying to wrap my head around commercial insurance. No, I think there's so that's a whole presentation unto itself. So comparing the US and Canadian healthcare systems, there are certainly advantages to the US healthcare system, some of which you know. TMS, for example, is not approved. So these trials were produced in Toronto. The Canadian government still hasn't funded TMS in Canada, which speaks to how rigid the Canadian healthcare system is and how inflexible it is to taking on new treatments. It is approved here. Most commercial, in fact, all commercial insurance pay for TMS. Medicare pays for TMS. The only population that is not covered is Medi-Cal. So if not all commercial and Medicare do pay for TMS. So long as you can provide evidence that your patient has failed to respond to at least two antidepressant treatment trials. We just published with Corey a paper, almost an expose about why there's inconsistency between insurer to insurer to insurer. There is some inconsistency. Some require 4 trials, some require 2. But suffice to say that if your patient has failed 2 trials of antidepressant medication, you can get access to TMS.
Thank you, Dr. Daskalakis. From our web audience, we have from Dr. Goldberg. Thanks for a great talk. You mentioned that TMS is a path when meds and talk therapy are not effective. I'm wondering if there's research into identifying who would benefit from TMS upfront, obviating time spent on treatments that won't work.
So that is the kind of a holy grail question. It's a great question. And that's ultimately what we're after is trying to understand the biological predictors. I showed some data that suggested that you can predict who responds 9 out of 10 times. In MST, that is actually one of the key findings that got us the big CREST trial from the NIMH. And there's lots of work being done right now looking to see. Some of the early findings we had lots of excitement over. There was a paper that was published by a colleague of ours, Connor Liston, that showed that over 80% of patients would respond if you had a particular functional activation pattern in the brain that involved specific cortical areas. Unfortunately, what we found from functional neuroimaging studies is that they're not the most replicable. And so the challenge is to not only find a signal, but to replicate it. And once you replicate it, now the NIMH expects that you'll replicate it in a clinical trial to be able to achieve FDA approval. So there's a lot of work that's being done in this area, including our own. We're looking at neuroplasticity as a biological target through which TMS works, and being able to use neuroplasticity to be able to deduce who remits to this treatment. So great question. It's just not at our fingertips.
Thank you so much. I'm sorry we're out of time for further questions. We're so grateful to you again for your terrific talk, and we hope we'll see you next week. All of the audience for Department of Medicine Grand Rounds. Thanks. Thank you so much.
Where are you from?
Alberta.